Okay, colleagues, it's 10 o'clock. So I think we're here. Those that we're expecting. Is there anybody of any kind of empty chairs with names against where we're waiting on someone?
Richard.
Who's next? Richard Dales. That's right, he's coming back.
And I think we're just waiting for Paul.
Okay, well, I think we can probably get started even without Paul.
Yeah, and just to let you know, Alan Croft online.
Alan Cross online, and Alan Hughes is online. Oh yes, we've got a few. Oh good, we've got a few. Because it's public board, I can see the odd smattering of staff and governors. That's very good. And we've got the governor here with Keith Powell as the governor. So welcome to all those who are attending to observing. You're very welcome to this public board meeting. Let me check first of all as we start. Is anybody going to surprise me with any other business that I don't know about? No, that's good, so I don't need to leave too much time for that. Then, apologies.
Ruth Connaughton.
Ruth Connaughton, who's still holidaying, but is coming back shortly. We don't forgive her easily. I should say at this point also, this morning I've had the unwelcome confirmation that was expecting that Namita Kumar, who we very recently appointed as a new associate NED, is unable to take up the appointment as a result of changes in NHSE's policies. So she's been forbidden from taking up the role. She's really disappointed and very apologetic for the time and money that we're all involved in that recruitment process. But in particular, we will miss what I thought was potentially an outstanding appointment. So we will reactivate the process pretty well immediately to seek to once again try to further strengthen our board with a further clinical NED appointment. I'm going to take you straight into the minutes of the last meeting, 28th of March. I'm assuming correct, unless anybody's got any issues to raise. We have one matter arising. Kate?
Thank you, Chair. It was around the front entrances of the hospitals, and it was something that was raised with regards to compulsory hand washing. So I just wanted to give an update of where we were in terms of the front entrances. So it's like a little bit of background. During COVID, we obviously made hand washing compulsory, and we used a meet and greet service at a number of the entrances to the hospitals on each of the sites. As time's gone on and post-COVID, we've had a lot of discussion with the exec around how we take that forward, in light of the fact as well that we have a number of volunteers that also work at the front entrances of our hospitals. And what transpired, and it came up through the board walkabout discussions that were brought here by the non-exec directors, is that there was a number of inconsistencies across sites in terms of our front entrance, meet and greet staff and volunteers. Where we've got to, Chair, is that we have looked at the meet and greet service, and due to the fact that now we are saying that hand washing is not compulsory, it's absolutely, we would like the public and staff to wash their hands prior to coming into the hospital. It's not compulsory as a result of COVID anymore. We have looked to remove the meet and greet service at the front entrance of the hospitals. However, we have looked at the reception areas, and we've started them earlier now, so they start 7:30 to enable to greet patients and help them. And our volunteers are still at the front entrances of all of the hospitals. So it's just the reduction in the meet and greet service that we've enacted.
And will we evaluate the impact of that and see what people think,
yeah.
including what patients think about that?
Yeah. And I think it's a public thank you to the meet and greet service as well, Chair, because they've done an excellent job throughout.
Well, haven't they?
Yeah.
Haven't they?
Yeah.
Yeah. Anybody wish to comment further on that or ask about that?
One thing, yes, thank you. Thanks, Kate, for that. I think we will really monitor that quite closely. I've just been speaking to one of our NEDs this morning about an incident yesterday, and I think it's just about the volunteers that are there now, about their roles and responsibilities and any training we can give them. So we definitely will keep an eye on things.
I can understand the logic of the decision, but I just feel slightly uncomfortable with it, so I'll be glad to see the evaluation. Yeah. Good. Okay, then can we go on to the action log? Can I, first of all, I've got an apology, 1, 2, 3, 4, 5, 6. The sixth action was to regularly share a summary of constituency issues with non-execs. I think actually it was to incorporate it into the regular report that Bijou and I will be doing on, that's included here. But I forgot to action that bit. So I'll give you a quick verbal when we get to that item. And I think our expectation is in the future regular reports that Bijou and I will be doing on engagement and partnership working, we will include a summary of issues that have been flagged up by government. That's all I had on the action log. Anybody, any others? I think otherwise we're complete. Then let's go on. Bijou, your normal dashboard. I'm skipping my chair's introduction because I feel like I've done that and it will come up a bit later. So, the dashboard.
Yeah. So this is our dashboard for month 1, so that covers a period of April. And you will see that generally a strong performance in terms of our patient and staff experience, which you would expect. And even on our operational performance, despite it not being where we would want it to be, still within the region and nationally we fare well. Clearly there is a work in progress in trying to improve those metrics, particularly around the 4-hour standard, our elective performance and our cancer performance, the 62-day standard, that the teams are working hard on trying to ensure that we push those back up to the standard, the national standards that we have delivered for a long time up until COVID. Financially, we fare very strong, probably one of the only organisations nationally that still deliver a surplus, and month 1 we have delivered a strong performance. And then similarly from our workforce, whilst our sickness absence is not where we would want it to be at this point in time, it is being well monitored and tracked through our performance, both through our performance committee but also our people and OD committees. So generally the organisation is doing well. We are looking very much forward to starting delivery of our phase 1 of our clinical strategy, and we've got some big things coming on board with the Health and Care Academy opening next month, and also the Berwick build being well and truly underway, as well as a number of other capital programmes that the organisation is invested in to make sure our facilities are fit for the future for our patients.
Thanks, Bijou. This kind of pulls together a load of detailed discussions that are taking place in committees and groups across the place. So it's the opportunity to flag up anything really that even if you have previously done so in the committee. Colleagues happy to receive. I think it's striking with lots of green and orange. The traditional reds. I mean, those performance indicators are still, they're stubborn, aren't they? But the thing that I feel gratified by is that we're not just looking at, I just had a discussion this morning about the balance between crisis intervention and longer term planning. We're doing some proper longer term planning to make sure that it's not just we can handle the reds right now, but we can do so in a way that they will be handled properly in the future. Thank you very much indeed. Thanks for that. Then let's move on to what we've agreed now to have as a regular paper summarising our engagement partnership. It's particularly focused on our partnerships across the ICB and other partnerships, but it will also, in future iterations, include the opportunity to update on the issues that have come up through our governance. We've done this, happy to take comments on the format as well, incidentally, either within the meeting or outside, because it's our first attempt. So I've summarised, first of all, my meetings, both within the Alliance and within ICB, and some national events and some local authority events. And Bijou has done similar. Are there any bits you want to highlight, Bijou, from your summary?
No, just I think the two bits. Obviously, as you've said, we've covered off the national and the regional, and the Great North Healthcare Alliance has formed part of that. But some couple of big internal ones. So our excellence in collaboration with primary care, which is an event we run twice a year, really important for our primary care colleagues, and it's a great opportunity for us to work closely with them to share our learning, etc. And then also probably the first big launch of our Trust Clinical Strategy event. Again, that happened in April, a really positive event that started to really raise the profile of how our next clinical strategy will land over the next, it'll be a long-term period over the next 10 years, with some key changes happening in September. And then finally, the Staff Awards, which took place in April, a fantastic event with which we recognise some real heroes within our staff.
Great. And before I just summarise the issues raised by governors, are there any questions or comments to myself or Bijou on that report? Governors, it's really striking actually getting the list of the issues that have been raised in the last quarter. How many there are and how many we can indicate that there's been action on. In Berwick, they regularly talk about access to services in rural areas, and if Richard Dale, who's coming late, if he was here, he would be able to say more about the thinking on that. And Katie, I know, has been involved in a seminar on rural access. We also had a really good discussion at Berwick around the proposed changes in NPC provision with Harbottle, and it's one of those examples of where, from governors' views combined with others, there was a change in policy in practice reflecting the governor's concerns. There's been discussion about dental access there in the Berwick area, which is seriously problematic as it is in many other areas, and the governors there have been very much involved in following the details of the hospital build, not just celebrating it, but also having constructive comments and suggestions of how things could improve. Blyth and Wansbeck governors tend to have lower turnout there, but we've had good discussion about the Blyth refurb plans and the issues of food that we've been talking about here at Public Court and elsewhere. Hexham governors are always lively, and there's been a lot of discussion about the theatres reorganisation there. Very constructive, very positive, and really helping us think through the communications issues and the staffing issues. They've always got a real interest in the estates, in the signage, in the gardens, etc. They keep, and the parking. They keep us on our mettle there. It was from there raising concerns about whether we've got the complaints policy for private patients right that led to the review and the new complaints policy that's now been issued. They've raised issues and concern about CAMHS, about the availability of child and adolescent mental health services. And they, like all the other governors, have often discussed the alliance, the opportunities and also the risks from it. North Tyneside, we had a brilliant food session where Damon and Damon's colleagues brought in a range of the food so we could actually trial and test it. It was great, that was fun. We've had discussions which are still not completed on podiatry and access to podiatry. We've had some really detailed discussions on the outcomes of some of the place visits, including some of the concerns that were raised, where we've managed to move in response to the issues that governors have raised with us. And the co-opted governors have raised concerns in relation to the alliance and in relation to the partnerships with Newcastle. It's realistic we'll lose our best people from Northumbria who'll go shooting over the border to Newcastle. We're seeking to provide all the necessary assurances with there, but they're very enthusiastic about the opportunities that might come, for example, from the increased opportunities around sharing our research activities and many other things. Next time, I promise you, we'll incorporate it in the report, which will give you more chance to reflect rather than have to respond to a short list like that. But I'm happy to take any comments on that. I think my overview is we have a lively set of governors. I'm delighted to say that. We have a range of issues that are brought up, and I think we can demonstrate that we do our best to respond to them all. We don't meet everybody's wishes, of course we don't, but I think we have evidence that that issues are taken forward in a proper and considered manner. Bernie.
Yeah, thank you, Chair. I think that was a fantastic overview. It's, I know it's a kind of new thing that you're introducing, so just I think to get that kind of succinct overview of all of the feedback from the various constituents, because we all get involved in different ways, but we see that in one overview I think was really powerful. You know, the valuable insight and contribution from his governors, I think. So thank you for your summary, Chair. That was excellent.
That's good. Thank you very much. Can we move on then, please, to the first item for approval, which is the equity and inclusion narrative. And this is kind of potentially the final stage in a process that's been rolling for some time with early drafts, etc. So I'll certainly take any comments and I'll invite Kate to introduce it all, but we've gone over this in various iterations in some detail. Kate.
Thank you. I was going to mention that as well. So this is our equity and inclusion statement of intent. This has been work in progress for quite a while, looking at how, as an organisation, we can really show the organisation what we mean by equity and inclusion, which we think is extremely important. This has been through a number of iterations and through board development with comments from a wide range of people, staff networks, the board, and a number of members of staff. One probably point to raise is that there's been an agreed shift from using the term ED&I, which is equality, diversity and inclusion, to move to equity and inclusion, which we feel more accurately demonstrates our culture of fairness for patients and staff and in our employment practices. So I welcome any comments, and I think the three areas which we really want to encourage people to look at and listen to what this means to us. It's those individuals, we treat everybody equitably, and those with protected characteristics. We understand inequalities, and that what our community promise means to us, and they're the three areas that we would like to bring to attention.
It's a good piece of work, making it simple and clear. Equity and inclusion tends to be quite a complicated area where we can end up drowning in terminology. Bernie, as Chair of People and Culture, your comment first?
Yeah, thank you. I think it's a great piece of work, Kate and Patrick and others who've been involved. It's one of these things where it sounds easy just to kind of come up with some new narratives, some new definitions. It's much more than that, and I think the team are doing well to refresh and reset our narrative on it in terms of equity inclusion. And I think in particular the kind of the focus on the specific actions against those kind of key points, I think is really helpful. So I think well done. It really gives us a much clearer and better focus to push on and build on the great work that we've already been doing. So I think it's a commendable piece of work here. So thank you for that.
Thank you, Bernie. Any other questions or comments? Yes.
I think it's just worth adding, I think this is said in a supportive way, the simplicity of the message, I think, is what's really important. I think we can and do have a tendency to overcomplicate, so people think this is something that's really complex, and actually a lot of this is about human behaviours and being mindful of those around us, wherever walks of life, wherever they come from. So I think I would really value the simplicity of the message within this, and that there's, for us as an organisation, these three things that we will really focus on under this banner.
Very good. Are we happy to approve this? Approving the equity and inclusion statement. Thank you very much indeed. Thanks to Kate, and thanks to all those who've been involved in introducing this. Excellent, let's move on. Item 3.1, we're into the performance section, and the first one is an update on the Great North Healthcare Alliance. Andrew's got a promoted on leave on the admins, but his able deputy, Bijou, will speak to the paper.
So you will have seen the paper in your packs, so I'm not going to go through it in great detail, but you will see that the paper outlines and reiterates the overarching vision of the Alliance and what we aim to deliver, remembering that that alliance is between ourselves, Newcastle, North Cumbria and Gateshead, and then some of the areas of focus that the respective teams have been working on. This is by no means the only areas, they're just some key headers. We've discussed this on a number of occasions with our governors, and there are a number of suggestions that have come up from governors that are also incorporated into a wider plan. There's been some further work in terms of bringing the respective boards together, which again has been a really positive step forward. So respective non-execs from each board as well as directors have got to meet each other at an event that was held earlier this month, in fact. And those work streams now continue to work together, including between non-execs, but also medical directors, nursing directors, finance directors, etc. And we'll keep bringing back, obviously, regular comms through this route.
Interesting, at governance last night there was a question about, is this secret or can we share it? And of course the answer is it is not secret. And so the information in here, we might want to just make sure we, I know we've separated it again, but it's one of those things we just need to keep on bashing out to people, I think, to make sure they understand what we're really about. Questions? Comments? It feels like we talk about this now at every meeting, and sometimes it's at a moment like now where there's no immediate fundamental decision to take, but this is becoming part of our life, and it's important to keep it uppermost in our minds. Any questions or comments on it? Then thank you. We're noting the progress made, and let's move on to the next item, the business unit, medicine and emergency care business unit. Simon and your colleagues.
Indeed, yes. So thank you very much for letting us come and speak with you again today. So I'm Simon Eaton, I'm the Business Unit Director for Medicine and Emergency Care.
I'm Swallowy, I'm the Deputy Director for Medicine and Emergency Care.
Paul Manley, Deputy Director from Medicine and Emergency Care.
So we're going to do a little three-person presentation, but I'm just going to start off by, in a sense, I always put this slide up, Paul will notice, the budget number increases year on year, not as much as surgery, but,
Not that you're competitive.
the bed numbers, we'll get to that at the end. The bed numbers are increasing a little bit, but the rest is pretty much the same, but it's just to remind people that whilst we do, quite rightly, get involved in conversations like this at this point around our emergency care component and the diagnostics and outpatients of some of our big specialties, just remember that we are a very wide-ranging, heterogeneous business unit with some things that can easily be forgotten, and we do try very hard not to let that be the case. So Paul's going to talk a little bit about the elective side, and Marcus the emergency, and then I'll talk about some of the achievements and plans.
Thank you. So yes, I've got the elective performance slide. So as you can see on there, we've, for medicine as a whole, on the top slide, we said before we start to play. How's my voice going? Is that any better?
Yeah.
Okay. So picking up the top slide, the top table, we can see the areas there. As a business unit, we're above 92% for RTT, but the areas in red are elderly.
RTT?
Referral treatment, sorry. Are above 92, but rheumatology and elderly medicine are the areas with the focus that we're working on as well. We've set a target of 4 weeks for first appointment in, and you can see there on that column of how long people are waiting. So a few areas are touching that, but our aspiration is to hit 4 weeks for everybody in every team in there. Going on with the appointment slot issues, we've done a lot of work to reduce those. There has been a little bit of a bounce back up on those. The graph is till the end of March, so we're sitting around 700, but we know it's gone up slightly again in April and May. Looking at that in terms of, is it a capacity issue, a booking issue as well, and trying to unpick all of that to start bringing it back down. You'll remember, I think last year we had a very aspirational target of aiming to get to under 100 appointment slot issues. We've realigned that to be 300 for this year, just in where we are currently, and making it a bit more of an achievable target. In terms of A&G, so advice and guidance, we're looking now at putting all specialists through the single point of access. We're doing a lot of work, some pilot work in other areas as well, to kind of start small and build up on there to make sure we've got that processes in place. And just going back to the DNAs, we've set a target of less than 6% appointment DNA rate. So in terms of trust priorities in the top corner, we don't have any 52-week breaches, and actually our internal target in medicine, we've set that to be no one waits more than 34 weeks, so working to that standard. We've reduced our waiting list size. It's currently in medicine sitting at just under 9,000. which is about 25% of the overall waiting list. And I mentioned earlier about the RTT performance as well. And the next slide was just a bit of a summary slide really for our elective performance. So end of year position was very strong, those figures in green show where we landed for income activity, and the bottom one is just where we started April in a similar vein.
And just for clarity, when it says 125%, that is compared to performance in 2019-20?
Yes, yes. And the target was 108% last year, I think it's been 115% this year, so it's shown good performance.
The 2.8 is £2.8 million income that came as a consequence of that.
Very good.
Cheers.
Should we take questions after each section, or do you want to wait to the end, Sam? Is it?
Probably wait to the end and then, is that all right?
Yeah.
Is that okay?
Okay, thanks, Paul. So this is a bit of an overview of the 4-hour A&E performance, which obviously is a key indicator for us. As you can see from the right-hand graph, we have had particular challenges over the last few months in terms of volume coming into the A&E department and challenges in relation to flow. It's probably fair to say, and I know Simon will pick this up on his slides, this is a key area we'll have significant focus. We're not where we want to be. We know the reasons why, and we've got plans in place to drive that forward as part of the key part of the strategy that Simon will go through as well. Next slide. Ambulance handovers, again, another key indicator. We're working again very, very hard on this. Over the last few months, we've set in place a number of after-action reviews. So what we tend to find, particularly for the bottom left graph, when we have 60-minute ambulance delays, that tends to be a batch of them, not necessarily every day, which is sometimes linked to flow, sometimes linked to surge management. Since November, we've had a pilot in place with NEAS, and we've implemented a significant amount of changes for the clinical team, which has been driven by the Deputy Head of Nursing. And what we found during that period, the 11 weeks before the pilot and then 11 weeks after, we've had around about a 14% increase in the ICB in terms of ambulance attends. So it's around about 900 more ambulance attends compared to other areas. We have, if you look at the graph, that we did start to make improvements in December, then it went up a little bit in March and back down. So we have made those improvements in the context of more volume coming in, but again, this is a key area that we're determined to drive down. Our aspirations absolutely have no 60-minute ambulance breaches. Again, on 30 minutes, a similar challenge, and we've got various after-action reviews in place to review that as well. But it's very much a team effort combined with improvements that we're trying to make in the wider system, which Simon will go through. Exciting. And this just a little bit of context really. Whilst we're not where we want to be in terms of the target for the trust in terms of sickness from an HR point of view, we are making steady progress in that area, and we're proud that the team are working really hard on that, and that's despite some of the challenges in the background. And also that the turnover rate is significantly improving over that time. And we know from Jo, from her feedback, in terms of staff experience, and there's some areas as a medicine business unit department coming really well on, such as things like having a voice or compassion and inclusion. I think hopefully that's a reflection of a lot of work going on in the business unit to work with and engage the staff teams.
Okay, so just these are just some really headline things, mainly achievements against what we talked about at the last presentation to Trust Board. But and not wanting to run through this word by word, but one of the key things I think we'll probably end up talking about in the questions as well is what's going to happen next year. So we've done front door screening from a pilot. So this is people coming into NSEC and somebody at that front door saying, are you in the right place? So our aspiration is to make sure people get the right care in the right place all of the time. And very often that's not necessarily the emergency department or even the NSEC building. So that went from a pilot to being 3 days to being 5 days currently, and will be running 7 days by September. And we are very much working on making sure that there is capacity within the alternatives to admission and alternatives to the ED to make sure that people are able to go to the right place. And one of those includes the LD Assessment Centre, and again, that's something that we've worked up. It's been running 3 days currently. We're getting it towards being 5 days. We'd hope that would be there now, but there are plans in place around that, and is working very well with the single point of access, community services, And when we build that to be regular and build confidence in the system, we're hoping that ambulances and GPs will automatically think about, is this something to go to the urgent assessment centre rather than going into the NSEC machine. We know that when we're talking about staff experience, that sometimes, not always, but sometimes we are scoring lower in certain places in staff experience. We expect that. I think that validates the staff experience thing, because it is where the pressures are. So if everyone was saying yes, it's fine, we would be in trouble. We are certainly not resting easy on that. So we've been doing some very targeted work, trying to understand it at team level as well as across the business unit, what the issues are and how we can help address them. Keeping the teams going, keeping them at the top of their game is the only way we continue to get through all of this. The discharge lounge is now, we need to rename it because it's now open 24/7, not just to help people leaving hospital today, but also potentially boarding capacity. So people going home today could go up there last night, so that bed on the ward could be used for the post-take round this morning, etc. So that's up and running now. We've had a lot of work finishing off at Wansbeck. So all of the subacute wards in Wansbeck and North Tyneside have now been redeveloped over the last couple of years. We've lost some beds, we'll come back to that. There's a little bit of work ongoing. We had Ward 18 at North Tyneside was our escalation ward during winter, anticipated for 4 weeks in early January, ended up needing to be used a lot longer than that and on more occasions than we anticipated, but people, nurses and doctors and all the teams involved in this came good to deliver that, so that allowed us to get through some very difficult times without any impact on elective work, which in the past when we've needed to go into Ward 3 at Hexham or wherever has had an impact on elective work. As Marcus alluded to, we're constantly working on trying to keep the workforce as productive and as positive as we can do. In terms of our key actions, so we recognise the pressures in the system. So we've had more attends than ever before, more admissions than ever before, and more ambulances than ever before, and all of that's impacted on performance, but that's still people who require the care that are not getting it in a timely way. So we know we can't just rest back and say, well, it's busy. So we are looking to re-provide the bed numbers that we've lost through the refurbishment. We've seen this year that we have missed those, and so we will be opening an extra ward. It will be at North Tyneside because we need the empty ward at Wansbeck to help with the Blythe changes in the coming years, and that will be open into this autumn to be those extra provided beds. We are also doing this work around the front door, trying to make sure people are getting the right care at the right time, and there's been a lot of progress onto that and a real step change intended for September on that. We've got our constant obsession almost around flow and how we can make sure we're using the beds as effectively and productively as possible, and including making sure that some of those things are in our control, some of them are with our community and local authority partners, and how we're working with those to try and avoid delayed discharge, and some ways of being able to count in real time, get a better sense of what's happening so we can make sure that we are optimising things as much as possible. In addition to the extra ward, Blythe ward is currently getting refurbished, and anyone that's been on a visit to that in the last year or so will know how important that was to do. That was necessary, even though in a couple of years' time there's likely to be a large redevelopment of the Blythe site, but it just didn't feel tolerable to keep going in that situation. So we are doing a refurbishment at the moment, and they'll be back into this refurbished ward shortly. And Ward 22 has had a refurbishment at North Tyneside prior to the new ward being, so we're using the decamp space whilst we can before we get to the new ward. We absolutely intend to continue our performance around elective work, and we're very proud of that. There's a few areas we need to work on as ever. Continue to work with our workforce. So we have, again, very proud of having good recruitment, particularly in nursing numbers. That's been a really different situation this winter to previous. But what we need to do is see a reduction in our agency spend as a consequence, and so people are really working on that. When we've been in escalation, we've essentially, it's not quite as simple as this, but we've essentially just chucked doctors active and pharmacists and other sorts of things. We need to make sure that we're getting really tight on that and using the workforce that's available to us before we just get other people around, although at times clearly extra workforce is needed. So we absolutely need to work on that. And there is some ongoing work around, in particular, because it was mentioned on previous slides, the insulin pump work. I think people might know I've got an ex-diabetes background. It's a frustration to me that we're not making the progress on that we need to, and we're going to. As that. So finally, the eagle-eyed of you might notice that this looks very similar to the slide we used before winter. I've just changed the top line to say, yes, it was a very tricky winter, it's what we anticipated. But I do want to just keep emphasising, there's one bit of this I want to come back to, but that we're not just in survival mode, we are constantly trying to evolve and change and innovate and improve. There's big ticket things and there's day-to-day things we're constantly doing. Marcus and Paul and the teams that they work with are working on that all the time. Our overall teams have continued to be amazing. I'll never change that slide, but it's we can't take that for granted, and we're just reaching the point now where we're trying to get back into the summer, the away days, the thank yous and that kind of stuff. A really short, deep breath before we go back into the waves again, and there's lots we're proud of. Elective stuff, I'm going to miss one out, come back to it. The clinical strategy work is important. That's the front door stuff has come out of the clinical strategy. It's now really evolving into operational winter planning. And wanting to make sure that our services are still ambitious and innovating and moving forward, and it's not just about surviving the day. But the bullet point I went over, and this line, we're still performing better than anywhere else, but not where we want to be. We know that isn't a tolerable line, really. And also, actually, to the two people to my right, we're not actually better than anywhere else at the moment. We're second, possibly even third now. My take on that, and I'm a bit too, actually you're out of action, you can't hear me, it's fine, is that what I want to say to the board. From my perspective, I can tolerate being second or third. None of us can tolerate being 8th or 14th or losing it. And we have seen both locally and elsewhere when people have lost grip of performance, it keeps going and they never get it back. And so we've got an absolute commitment for that not to be the case. For us to get back on top of it and in grip with this. We're making some really big ticket changes to help us with that, and get that performance right back up there. So we are definitely not where we want to be. We're definitely not resting easy on. I'm going to say it's reasonable rather than good performance, because it hasn't been, because people have been waiting far too long. We're proud today, Marcus will attest, we've had 4 days in a row where we've not had corridor care and ED. It sounds like a small thing to be proud of 4 days, but we haven't had 4 days in a row that we've been proud of in that way for a very, very long time. So, and that's progress, but we clearly want it to be much more than that. Thank you.
Simon, Marcus, Paul, thank you very much indeed. Really helpful, really encouraging in many areas as well, and I think it's fair to say I think the board really does know that you've got a grip, that you're not satisfied with where we're not yet, where we are. We know that. I think the thing that I've found most gratifying in this presentation is the focus on the long-term changes that hopefully will be able to embed the improvements that we're all wanting. Let's open it up for questions and comments. Margaret.
Thanks guys, really positive report. But one of the things I'd really like to have a bit more clarity on is rheumatology. It is an absolute outlier compared to everywhere else, and it was mentioned, but we haven't really gone into any detail, so could I have some clarity on what the plan is to dramatically improve that, please?
Yeah, so I'd love to say there's a simple answer and we can fix it straight away. I think rheumatology, it's very complex in terms of the patients we see, how we follow them up, and the kind of the way we work across the MDT as well. So we are looking at pathways within it and how we can divide up and change treatments and look at other areas. It's going to take a bit of digging and unpicking to get there, to be honest, because the pathway, as you can imagine, these people, once they're in rheumatology, that is their pathway. So we're looking at alternative ways, using HIFU and everything else to kind of change that bit of it. Part of it is a capacity issue as well, and being able to see the volumes of patients coming through. We've just recently recruited a GP with interest in rheumatology as well. We've got pharmacy roles within the service and very different NDT roles, so we're working on that side of it as well.
So could that come back to board at another time?
We were just
please?
discussing how we best come back.
Yeah.
So
So we can pick this up through all business units come through a business unit assurance meeting with the exec, so we can make sure that that is picked up through that route.
and maybe, and then as a consequence of the flow, either through S&Q or
Yeah,
direct-
or through,
yeah. Thank you for raising that, Margaret. Bernard.
Yeah, thank you, Chair. And thank you for the presentation. Excellent stuff. I'm immediately drawn clearly to the people and staff experience type elements being chair of the People and Culture Committee. And we've given the deputy directors in particular a bit of a tough time around sickness absence and turnover, attrition and vacancy. So congratulations and well done, because I think in my almost 6 years, I think the vacancy factors are as low as they've ever been and the retention's as good as it's ever been. So that hasn't happened by chance, it's happened because of a huge effort. Sickness absence is a little bit stubbornly high, but we're kind of assured. I mean, these guys are on it, like, in a supportive and well-being way, but if we could get that down, that would be fantastic. But we know it's a huge challenge. But in terms of just the positive thing, because we look at performance and we often look at it in the negative. We're not meeting the 4-hour standard is a typical one, and it feels negative. And you've had 4 great days, and you're second or you're now potentially third, and that doesn't feel good. But I think somehow we've got to kind of keep reminding ourselves to celebrate those, even if they're just small wins or 4 days of wins. We've got to build a positive narrative, because I think it's easy for us to get into a consistent negative narrative, and that's not helpful to anybody. You know, the positivity will breed more positivity, you know that, but I think anything we can do as non-executives, and I think as a board, we should be full square behind you, celebrating the positive things, because there's huge, huge efforts going in.
Yeah, so just on that point, Bernie, I think you've heard me say this before, we know across our board, so this is not just about ED, that time is really precious, and the one thing that we know our patients tell us about over and over again is waiting time. So they don't like to wait, be that for a diagnostic test, be that for an elective procedure, or be that for an ED attendance. And I think the narrative very much more internally now is about having that performance with purpose. So actually, it's not just about hitting the top spot, although clearly that is where we will be hitting. But it's about having that purpose behind that performance, and that purpose is about improvement, and it's about making those milestones more achievable, and it's around waiting times that we know our patients, it's important to our patients, it's important to our staff as well. So I think very much that is something that we are asking the organisation to engage with, rather than just saying, have you hit the 95% standard? It's what sits behind that that's important.
Jeremy.
Thanks very much, Simon, for all your hard work and efforts. I'll hold my comments on the performance for the moment. As you know, I'm getting anxious about all of these things and don't like corridor care at all. The bit I'd just like to ask about is I'm pleased to see about the elderly care assessments at Wansbeck. And I know we have something at Hexham, but I'm going to ask about North Tyneside.
Should we keep giving the hard questions to Paul? I won't just.
You can give this one to Paul if you like.
I think yeah. Okay.
It's a good question.
No, being honest, getting elderly assessment centre up and running has been a bit of a struggle in terms of coordinating the teams, the staff. We've got a really good way of working now with community, which has been paid dividends. So I think our question is yes, we'd like to do something at North Tyneside. We want to get Wansbeck working how it should be working. I mean, we're not there yet. We're not consistently seeing high numbers every day. We're not diverting 5-10 ambulances away from NSEC. I think once we've achieved that there, the question is how do we do it down for North Tyneside? We do see patients. When we did I've alluded to it before, but when we did the Perfect Week, we did actually see patients from North Tyneside come up to Elderly Assessment Centre at Wansbeck as well, because we wanted to kind of use that resource across everywhere. So aspirationally, it's on the revision of where we want to get with elderly assessment units.
So I guess, you know, it's really good to see we've identified that cohort within ED that you might call as perhaps primary care style patients, and they're streaming those away. But I think there's a cohort across all of the patch. It will be smaller, but if we admit patients of that type, the bed impact of those individual patients once they get there will be significant. So I think that would definitely be on my must-do list.
Yeah, and just to you articulated but to explain it further, it's there's a group of people that probably don't benefit from being in the NSEC machine and may lose from having long waits when they either need to come into hospital, and only a small proportion of people coming through the LDS that are getting admitted, but they're quite often getting admitted to a base site. Or actually managed to get away that day after a detailed multidisciplinary assessment that they may well have got in NSEC, but they'd probably waited in ED overnight for it, or been on a ward and then cobbled together the next day. So it is important. I think the elderly medicine service is very stretched. We're asking every bit that we touch, the inpatient beds, the community working and virtual wards, the specialist clinics, and all these sorts of things there. Pulled in lots of directions, so they're struggling a little bit with that. Paul and I in particular are doing some work just trying to help, because we think there probably is a bit of capacity if we, without using the, but work a bit differently. And I'm hoping if we can get the OneSpec one up and running and show that because it's not high impact at Hexham. And essentially at Hexham it's just like Paul and Leeds have done. And it's trying to get to the equivalent to that, so it's not seen as another massive thing, but just part of what we can do if we're working as a base site effectively. So it's on the radar. It won't be this year.
Good. Kate.
Thank you. And just a quick comment. So on your key achievements for 23-24, you talk about well-being and work-life balance, which is great, and you've made some real great inroads in there. It would be good to see then also on your key actions for 24-25. So you talk about medicine workforce strategy plan. There's a long way for us to go on elements like flexible working, and we all know that flexible working reduces sickness absence. And I think, especially in medicine, some of your difficult areas, there's something to look at there around self-fostering. Flexible working is something very different for everybody, but it'd be great to see that in the plan for 24-25 and how we can increase that to decrease other things.
We have got the 8-page plan. This is just the 5 bullet points. Good.
Yes, Phil.
There was just a similar question on the discharge lounge. We mentioned it in terms of one of the achievements, 23-24. What's the plan for 24-25, and what's the new name going to be?
I'm Mike.
Your job to answer.
A schoolboy, aren't I? The name we're just talking about outside. We need to change the name. Please drop us a note if you.
A little competition coming on.
So that's one thing. There's also we had a place visit recently which we've made some improvements to the discharge lounge, really helpful feedback. But around things like access to televisions and those types of things, which we're going to resolve and take forward. The vision for it moving forward is still, it has to be a short stay area, so it's somebody who's leaving the site who's being discharged. If it's someone who's boarded with a plan for the morning, they should be leaving in the morning. It's really become part and parcel of our system set up at NSEC, where previously it used to be kind of like stop-start. So the aspiration for moving forward is quick in there, out of there, moved on, a new name, a good name, with a bit of support from people, but also continue to get feedback from patients and staff about how we make improvements.
And just on that front as well, nationally there's a drive to have all discharge lounges or whatever, the equivalent of 24/7 as well. So I think it's helpful that we've already got that in place.
I did suggest departure lounge, but we weren't sure what we were doing.
So we're going to call it the Log Lounge, unless somebody comes up with a better suggestion in the next 7 days.
Sponsorship for that.
Just to, people say, but it's not great experience for somebody who's moving. I'm going to go home tomorrow. I've got to go up there and go somewhere else. But it gets the person that's in the emergency department onto ward, who this morning is now being seen by a consultant on the post-8 round and getting a really finalised plan, which is the definition of our hospital. And without that, they might not get into the ward into the afternoon, and then the plan might take a bit longer, and it just slows everything down. So it's probably, I don't want to call it a necessary evil, don't minute that, but it just helps us with the flow, even though it's actually not quite what anyone would want. We definitely don't want people spending prolonged periods of time in that environment.
Okay. No.
Thank you for presenting. I think there's been loads of work going on. It's just about length of stay, and I can say that because surgery are looking at it as well, because I think we've seen an increase in that. And it's just really what are you doing about it, if you could just share that with the group.
I thought it was a joint effort, actually. So, Lauren's a really good question. We've been looking quite in detail, as you'd be aware, because I've spoken about length of stay on the, particularly on the NSEC site and also the base sites. I think there's a couple of bits for the NSEC site. We talked to the staff team, we had all a big engagement session last week. We absolutely need to aspire for patients being discharged or transferred in a timely way within 48 to 72 hours. We were around about 4 days length of stay last week. That's come down to about 3.5 this week. So we've definitely made some short-term improvements. But I think the challenge for us on the site, despite the pressures and things like that, is actually how do you keep that flow going, how do you keep that down. We aspirationally definitely don't want to be in 2 escalation areas, because we know that is a significant challenge for us on the site, not just for medicine but also for surgery as well. But we're working through that. But we've got a series of engagement sessions with the staff, and some of it's rigour. It's making sure we know where every patient is in the site, and that if there's a blockage with that, we're working collaboratively with Safeguarding, the local authorities, mental health, because it's not always straightforward. But we feel we've got a good grip on that, but we feel we could be doing better. Paul, I don't know if there's any for the base sites.
Just one thing that I think it comes in about that rigour bit. It's about that bit of real clarity on the base sites. We're doing the site brief and real clarity on who are we targeting today, who are the people that we need to get out for progress the next steps, all that kind of thing, and coming back with touch points during the day, so we keep that communication going and actually saying, right, next step is doing it. So those are little tweaks we've made recently that we're starting to see bits of the kind of fruits from that in terms of just tackling those challenging ones all the time.
Yes.
Thank you. So just going back to elective performance, got really strong elective performance here. I was wondering what your thoughts are in terms of trying to spread some of that the way we do things and helping, especially our alliance partners, to help them achieve a better level of performance across the whole alliance rather than just.
Because 132% in April is outstanding. It's extraordinary.
Yeah, and some of the RTT and the waiting times in terms of first appointments. It's like, how can we spread that good practice? How can we help others?
No, it's something we're kind of already doing bits of, Chris, in terms of sharing it with other teams. Some of the work we're doing, we'll have actually teams come and ask us from around the region, one from a capacity point of view as well, about is there anything we can do to support from that side of things. But Chris, you'd be aware of the work we did with Oxford as well, Gastro, and kind of looking at the bits down there. So you're right, we need to share it, and we need to, but I guess not just share it across all the alliance, but internally as well, because we've said in medicine about our targets to get everybody to 92%. There's lessons to be learned from each team as well. There'll be lessons to share across surgery and other areas as well. So very keen to be linked into anything around sharing and developing that wider.
Is you then will probably need to wind up.
So I think there probably is as well something within all of that about making sure, I'm going to say particularly within medicine, that some of the successes that we've seen with the outpatient transformation, particularly around respiratory and gastro, is across all of those subspecialties, because we know there's a link between sorting your elective weights out with what that does to the emergency front door. We tend to think of them as 2 separate things, and whilst we manage them separately, there is an inextricable link between the 2 flows of patients. So absolutely, in terms of spreading the learning wider internally but also externally, but being mindful of the link that they have in terms of the emergency pressures that we see. And probably one other thing, I give my thanks as well to the business unit. I know they're under a lot of pressure in terms of the front door. It's something that we see on a regular basis, and it can feel sometimes relentless to the team. So again, personal thanks in terms of what we do.
Excellent, and I suspect we all share that last point. So first class presentation from the 3 of you. Thank you, both for the content, looking at the immediate and looking at the long term, and for the openness within it. No attempt to disguise the areas where we know there's still improvement to be made. Thank you, Marcus. You acknowledged with the discharge lounge the issues that have been brought up by governors, which have been reflected in practice, and thank you for the reactivity that you and your colleagues were able to show in that. We know that there's more long-term stuff to be done, and we're going to be involved as a board in those discussions in the coming period. We've got more to do on rheumatology. We've asked to come back, and we've heard how that will flow back. The board will hear more in the hope that that blip outlier starts to close. We've heard that the sickness levels are not yet where we want them to be, but there's impressive work underway to seek to reduce it. We've been reminded of the importance of celebrating the positivity, not always just remembering that we're not yet hitting the 95% and that we're no longer top of the tree. The reminder of positivity, I think, has been really important. We've heard about the discharge lounge, but we now call the lob lounge. We don't call it the lob lounge. We've heard that we're going to do our best to be getting back to the increased length of stay, which I think we have cause to be proud of, and we've had discussion around what we're already doing and sharing best practice. Thank you very much indeed.
So just one my esteemed colleague suggested the lobby out lounge.
Lobby out lounge, not for militant, for fear that coming to bring people start thinking of it. Yeah. Thanks very much indeed, colleagues.
Thank you for your support. We needed it. Thank you.
You've got it. You've got it for sure. Next up, comms and engagement activity report from Ross.
Thanks, Chair. And Phil, you just gazumped me there. I was just waiting eagerly to say the lobby. But, so this is just our usual highlights reel from the quarter. I think paints a really good picture of how we're engaging with our system and our wider world. And I hope it demonstrates how we're actually having some real strategic communications against the big signals and the organisational need. A bit like the other report we talked about, I think you can sometimes get a bit lost in the charts and the dials, and I think the simple bit for me is how we're communicating and engaging with our patients and staff, and actually on that we're tracking really well nationally and locally as well. Just a few things to pull out. I think this period, a lot of work's gone into the Health and Care Academy, which I know you're going to hear a little bit about next. Lots around and real positive stuff around the building works at Berwick, Blythe and Hexham. A lot of support provided by MPC during a period of real growth and challenge for them. And then the launch of the Northumbria Net Zero plan as well. So real good spread of positive stuff. I think lastly, you'll be aware about the general election was called yesterday. So we'll look towards the next period. We'll enter from the 30th into a period of pre-election sensitivity, which will significantly curtail our usual pipeline of work that we're doing. So the next report that you'll see will be a bit sparser, I'm afraid, but I'm sure there'll be lots to keep us going between now and then. So happy to take any questions, Chair.
Thanks very much indeed, Ross. And as you've regularly flagged up, as we come into the election period, all the opposition parties will be rubbishing NHS achievements as a way of rubbishing government, and therefore we are at greater risk of public feeling even more that our NHS is failing. How constrained are we in countering that by saying, I know this is what you're hearing, but actually think it's really good?
It changes every time, really, and we're expecting some national guidance later today, which we'll be looking at. I think we're going to robustly defend our own local record. There's no issue with that. Generally, it's about the proactive stuff, which we're pretty good at. That has to cease, unfortunately, so it doesn't influence the election in any way, but we can robustly defend our record. And I think the important thing is that we're starting from a much higher bar, so we've put the hard work in, in peacetime to make sure that people feel we're open with them and they've had a real pipeline of positive stories right across the organisation. So it feels like we're starting from a good place, and we'll have some strong, robust plans on that.
Okay. That's great. And any comments? We're doing really well, and your team's doing really well. So thank you very much indeed for that. And presumably you'll share the guidance, or either you'll share the guidance, or you'll tell us what we can and can't do.
Yeah, I'll do nothing.
Maybe
The guidance tends to be hundreds of pages long, so we'll do.
Give us a briefing as to what we can and can't say when asked.
Will do.
Any more furthermore in that way? Then we've got a couple of annual reports to look at. First of all, the Emergency Preparedness, Resilience and Response Annual Report. Marion, you present this.
Thank you. Yes, you will have had an opportunity to read this, and thanks. And this was prepared by Alison Bywater and the team. There's just a few things I would really like to highlight. It gives significant level of assurance that we as a trust meet all its statutory requirements. And we have had this through our Emergency Preparedness Board, which Bernie is our NED on. The key things I would just like to highlight to you are the various work streams undertaken by the team this year, and that's been supporting NHFM and some planning, some downtime of utilities, also digital services, and also around the LIMS, which was our laboratory information management systems, and the ICE upgrades. We've also helped with all the industrial action plans, as well as any of the surge plans that we've done this year. A big thank you to Moira Davidson, who left us this year when she retired, and a big welcome to Bernie, who's taken over admirably as her successor. There was you will see in the report that some of the core standards were looked at very closely. This was a North East standard that we looked at. I was involved with it with Alison, because some of the information in there we felt just wasn't quite right, and this was North East wide. That has been rectified now. We're working together, and I think probably more closely as a North East group because of this, and looking at all of these standards. So that's been a very positive thing. We're also looking at going forward, 24 to 25, about what we need to do there. The usual thing about training, but also all about the incident management planning. And finally, we will relook at and constantly review capacity and things in that team, and also giving people an opportunity maybe to have a secondment in there, if that's something, because you learn so much from this kind of thing. We're very happy to take any questions.
Thank you. Crucial team, you don't need it until you suddenly discover you do.
Yeah.
Steve first and then Ross.
Thanks, Marion, very, very clear. It was just a point in the report which was about the portfolio template which had been issued by NHS but then pulled back by the ICB.
Yes.
So what's that
Yeah,
about?
so these are the things that this was part of the discussion I was telling you about earlier about the assurance report. So we're in very regular consultation now with us. It was something that they were going to put out and then they've actually withdrawn. So at the moment we are in consultation with it. There's another meeting the end of next month, and we are all able to give our views on it, and then a standard will be set. So feel quite happy about, well, feel much more happy about that than we did previously, because we weren't involved in any of that at all.
Absolutely. I suppose just to widen the question slightly, is it all ICBs who've pulled them back, or is it just our ICB?
There have been more than us, but generally it was more in the north.
Okay,
Yeah.
so NHS are still saying get this out,
NHS,
but
yes.
just a few ICBs.
That's
I
right,
see.
yeah.
Thanks very
So
much.
I think it was really good that we got the opportunity to actually speak up, and certainly at that time it was Jim, as our previous CEO, who was sort of pivotal in actually saying, actually we need to really step back, pause and look at this. So we're very thankful for that.
Thank you.
Do you know if there's anything else to say?
Yeah, it's been a bit of a tricky. The whole pilot or the assessment process was, I think the best way I could say it was a kind of learning experience. And we got the right result, we got the levels of assurance that we required at the end. And the portfolio in the health command and the change on health strategic command is a kind of work in progress. But we've sought and received assurance through the board, the EPR board, that we're not just waiting for a template document. The trust is on it, colouring its own kind of data and assurance behind. So as and when the templates come, it will be populated.
That's really helpful. Ross?
Mine was just a brief point to say thanks to Marion Allison and her team. One of the key things in in an emergency response is how you communicate and how you manage the media. And just for reassurance to the board, our team have been going through a process of revalidation and training around crisis, including a couple of upcoming live exercises, so that we'll feel we're on top of it and able to respond and support in the right way.
Good, any more? Noting then, in some ways it was more complex than we might have thought, that review process, and coinciding with the change in chair of the Emergency Preparedness Board, thanks to Bernie. But we've got to where we probably needed to be, and it's a sound report, and I think we can recommend it for approval from the board.
Thank you.
Okay? Yeah, that's great. Then the next report is a really, I'm sorry, that one was important, but the next one is an extremely important, Health Inequalities annual report. It's the opportunity for us as a board to almost remind ourselves of the degree to which health inequalities is at the heart of our work and our thinking. Jonathan's online. Thank you, Jonathan, for joining us as chair of the Health Inequalities Board, and Alistair is here. How are we handling that? Which of you is going to present?
Johnny's presenting.
Johnny.
And Johnny sends apologies for short answers.
That's great. Okay. Johnny, over to you. Thank you.
Super. Thank you very much, Chair. So, as I understand it, we're around a 15-minute time slot. So I was going to, we shared the slides in advance, but I was going to talk through around 5 minutes of slides, just to really provide a bit of context, and then really keen that there's plenty of time for you all to ask any and all questions you may have. Just going to full slides. Share that. Can you see my screen?
Yeah.
We can.
Can you see the full slides? Perfect. Okay, so this is the first. We've had the Health Inequalities Programme Board for 3 years now, almost 3 years. This is the first annual report, hopefully annual report that we've put together. The reason that we've done this now is twofold. One is that we're conscious that there's a lot of really great work going on across the Trust. The Inequalities Programme Board is the convener of that. But that it's really important to make sure that we're tracking that, documenting it, and also holding ourselves to account as to what are those plans next year to make sure year on year it's getting better. The second is that whilst when we set up the Programme Board 3 years ago, we were very much at the forefront and ahead of, if you like, NHS England and other trusts, that increasingly over the last year there's been more and more movement around trusts having to do more on inequalities. But it's really important that we show that we are out ahead of this, but also, again, make sure we're not complacent on that. So in the pack, we outlined the purpose. I won't go through this slide too much. This gives that overview of where inequality sits within NHS England. But one of the developments over the last year has been this the guide for trusts across the country as to what and how they should be doing in terms of health inequalities that was published a few months ago. So there's 4 areas that they cover. One's leadership, strategic focus, analysis and interpretation of data, and building capacity through public, we haven't moved on these slides, build capacity on public health expertise. What comes with that as well is this self-scoring system. So we as the leadership in the Programme Board, 6 or 7 of us have worked through this together to assess ourselves across each of these 4 themes. Now, to stress in many of these, they're quite challenging. For example, it will ask the question, is your data on ethnicity complete? We think it's pretty difficult to be complete, but we assured ourselves that we're materially above, for example, the Trust average. And that's, for example, on data, insight, evidence and evaluation, 71%. Some of that is reflected by, we think, some rather challenging questions. But in many others as well, we're, as you can see there, quite well progressed on that. So this is a really helpful, standardised, it's subjective of course, but measure that every trust will now be doing. And it was very helpful for us to look through what are we doing, what more can we be doing, and inform that plan for the year. So in the Programme Board annual report itself, we've got the 4 main sections. The first one is around that data aspect, embedding health inequalities as core business. And so this is where we've been looking at key health inequalities across life expectancy and then many of the core 20+5 areas. So core 20+5 is the NHS England Health Inequalities Initiative, which core 20 is the 20% most deprived, Plus covers many inclusion health groups, ethnicity, vulnerable groups such as homeless and so forth. And the 5 covers 5 key clinical conditions. So we report in there how we're doing in terms of inequalities in those areas. Then we've got this additional data report which goes more into a deep dive. And then also the NHS oversight framework, which is something that every trust has to report, but we've added some additional inequality measures on there. Then the third part of the report goes into some of the case studies, so it puts more colour to the data, and particularly as to what are the types of pilot work we've done over the last year, what have we learned from that, how have we improved health inequalities, or what didn't work. And then finally, on the year ahead, we touch on some key aspects that we want to pick up on further. To give you some flavour, this is again this new NHS England reporting framework where they've identified, don't worry about seeing the specifics on here, this is around specific areas that they've identified inequality should be measured against. The green boxes are those that are relevant for the trust, the yellow boxes are ones that are relevant for other colleagues, for example in primary care or the ICS. So you can see the formal reporting for the trust to do on inequalities is actually pretty modest. There's some on electric recovery, for example, some around smoke cessation and oral health. So it's pretty modest. It's very helpful that we can look at this, check, are we doing, if you like, the bare minimum, but also are we going further? And then this is the type of data that we're then playing back to these NHS England statement metrics. To take one example, for example, the third row down is looking at elective inpatients who are over 18 years in 2019, then we look at 2023, and there you can see there were 6,500 of them. You then have the split between men and women, and then the 5 blue boxes are the split across inequalities quintiles. And then you have that split across ethnicity as well. So this is the type of data that we're able to play back, is what are the health needs and how they vary across different domains of equity. And then the final slide I was going to share before moving on to questions was this year ahead slide here. So what we're very keen on doing is continuing to make sure these data, that the data is very much, keeps us accountable, keeps tracking where inequalities are improving, but also where they're not, and helps us therefore direct resource, direct pilot schemes to where that can be most effective. A big part of that as well is making sure we have that economic evaluation too, because we think in several of these areas, it's likely you have the win-win of improving health equity, but also actually cost savings. And did not attend appointments is a good example of that. So building on those reporting metrics is a big part for that, for us. In the last couple of years, we've had particular focus on that core 20, so that's the 20% most deprived. In some ways, that's the easiest to actually track, because that's a big population, a fifth of our population, based on postcodes, so it's quite easy to measure. Much harder to measure what those health needs are for different inclusion health groups, gypsy, Roma travellers, homeless, and so forth. So we're having a much deeper focus on that this year, in the knowledge they're harder to reach, but actually also will have some of the biggest impact. And then at the bottom there, you can just see some of our phase 2 plan for how we're planning on embedding inequality metrics in the trust day-to-day reporting as well. For example, you can see a couple of those measures there as well. So the key for us is really embedding that day-to-day measurement of inequalities, normalising that measurement so it's front of mind in terms of our business planning, and then targeting resources to where we think will have the biggest impact on both health inequalities, but also developing a clear evaluation framework that can demonstrate economic return too. So Alistair, I'm not sure if you'd like to add anything to that before we open to the floor.
No, I think just another example of this is there's a live consideration about how do we actually look at things like health inequalities into business cases. So actually up front, when we're looking at some business cases, do we actually bring in to the actual formality of business cases things like the health inequalities as part of that process. So that's something that's a live discussion in execs at the moment, just continuing on that upfront theme.
Good. Thank you. We're very fortunate to have the opportunity to be led by Johnny with his national reputation it's provided in his life. So before we open it up, thank you, Johnny, for the leadership you've provided and the work you've put in to support us. Stephen first.
Thank you, Chair, and thanks, Johnny, for a good presentation. As a member of the Health Inequalities Programme Board, I think it's a great forum. it is still, I think, ahead of the curve, despite, as you say, other things in government and other trusts catching up. I think it's great to hear that the year ahead is very much looking about embedding data to make that much more business as usual. But I think you've acknowledged that there's an awful lot of work still to do in terms of getting that data right, not least the just basic stuff like ethnicity, which is a problem across the NHS, I believe. In terms of the actual report, I've just got a few points and questions that I'd like to raise. First of all, just when is it due to be published? I think there's still some tweaking to be done, some proofreading to be done on it, and I think I'd like to see a clear messaging plan, a comms plan, to go with that once it's ready to go out. Particularly would like some more comfort on the health inclusion groups piece that you've mentioned. So on page 147 of the pack and 148, we talk about, and it's brilliant to see, that we're going to do some deep dives on the health inclusion groups. Johnny, you mentioned Gypsy Romani communities and the homeless. One of the issues we have when we're so good and focused on data is that some of these health inclusion groups probably go under the radar because they may not be statistically significant. So with that in mind, to move on to page 148, which is the red, amber, green self-assessment against the Inclusion Health and Plus Groups framework, it still feels a bit optimistic, if I'm being honest. There's just too much green there for my comfort. It doesn't feel like we could realistically put green against any of those things apart from the top one until we really do understand the needs of those communities better. So that's really my challenge back about, are we being in danger of being, in kind phrase, optimistic, but potentially if this is going out, we'll be seen to be a little bit complacent if we're saying we're greens against some of those inclusion health self-assessments.
Thanks. Johnny, do you want to respond to much of that? I might invite Ross to respond on the comms and messaging, but is it overly optimistic?
Yeah, thanks very much, and thanks, Steve. On the report and comms versus any of the optimistic, so we're, as you say, so final proofreading, working with the comms team for a public-facing, accessible, and much more brief, what does this all mean, and hoping to get that out then in the next couple of weeks, really, when ready. In terms of on the, I was just checking which rating you meant there, whether it was the trust guide or the Inclusion Plus Health groups. I think that's a fair pushback, Steve. One of the challenges we have, I think, is when some of this is defined often as, we found within the trust guide reporting, we've been quite harsh on ourselves, and then we went through it with Alistair, Kate, Jill and others. And actually, the words around, is there any work being going on, or are you aware of, rather than, are you doing everything? So it's certainly a balance. If you take so I'm very happy to take a look at those. The green ones obviously are around the workforce for inclusion health, which is the question of, do we have that workforce with specific roles for inclusion health, which we feel like we do. In there, we didn't feel, for example, understanding the characteristics and needs, we very much got as an amber, same with demonstrating the impact. So very happy to have a relook, and any specific line item you think would be best to have a relook, please do let me know.
Okay, and Ross, anything more you want to say on the comms side?
Not only that our team works closely on that, but we are refreshing the comms plan. We're actually doing a bit of recruitment as well, because we've lost a member of the team who work closely on that, but we'll be in a position to bring something back fairly soon.
Okay, good. Alistair and then Jeremy.
I think some of the...
Sorry, forgive me, Alan actually flagged up first. I do beg your pardon, Alistair. Alan.
Yeah, well done, Johnny. Great report, great work. What are the opportunities provided by the Alliance to turn this into a truly population-based piece of work that you're doing, or to embed it across the whole of the Alliance?
Thanks, Alan. So I'll start, then it'll nice to take everybody to Alistair. I think there's two big areas that I see real opportunities. One is the data, and the two are the actual pilots and the services. So on the data, one of our challenges are, if you take lung cancer, for example, we don't know whether a patient who lives, Ponteland's a good example, that is halfway between Newcastle and Northumbria. We don't know whether they've come to us, whether they've gone to Northumbria, and so that's very difficult then to actually get a good feel of what the care is. So the opportunity for better data sharing agreements that allows that fuller population health view, it is a really good opportunity. What that would then allow as well would be then a more integrated view on outside of the trust into primary care in that sort of broader alliance structure is can we set up more inequalities pilots that's able to capture that in a more integrated way. So I think in short, the work obviously that we at the Trust are doing on inequalities is clearly having a really good impact, but it could be much more holistic, and therefore the return both on health but also the economic return would be much greater if we could really maximise potential alliance opportunities.
Okay, thank you very much.
Alistair.
Probably a reply on both. I think Steve's feedback is very helpful. I think the difficulty is some of the questions are really, in terms of the way they were set out, as Johnny alluded to, if develop the workforce, are we developing a workforce around health inclusions? Well, the answer is yes, and it's therefore looks green, although the answer is that, are they in a position to deliver in terms of the outcomes? No, and it might be that some of the ambers need to go to red, but some of the greens might need to stay, simply not because we're being over-optimistic, but the question asked was quite simple in terms of that journey. I think the second, around the alliances, I think there's a potential for quite a lot of excitement around that, particularly if we look at getting through the correct information governance so that we respect patients' rights and etc. within that, but the ability to look at health inequalities and some of the population health across Newcastle, Northumberland, North Tyneside, and possibly bits of primary care. Conscious that this is always problematic because we need to be really cognizant of what individuals' preferences are around data sharing. But even with completely anonymised data sets, it could be a really powerful way of actually improving the health of the North East.
Excellent. Jeremy and then Joe.
Thanks very much, Johnny, and it's really great to see this first report as a sort of marker in the sand, and I'm looking forward to subsequent editions. I appreciate the difficulties of collating this sort of information in the environment in which we're all working, so please bear that in mind in my comments and questions, which are a little bit like Steve's, but it's just that the paper in the pack that I've got on the health inequalities self-assessment tool, the numbers are different to the ones that you've presented on your slides. And I have to say, probably your number of 73% and progressing on the data probably seems more accurate, but I don't quite know which is which. And I think it's probably important that we should publish the right one.
Okay, that's a checking process. I don't know where that will lie, but...
I mean, for clarity, I should have started by saying there's an awful lot of work gone into this, as you imagine, by largely not me. There's some really talented people in the team, Lucy Evans and Claire particularly. And we were planning on getting this ready for early June, but we were delighted with the opportunity to come today. With that means that the version that we submitted to the board, that paper, was prior to our internal conversation and that re-rating. So quite simply, it's different versions. So the PowerPoint slide is the updated version, which the newest, the version of the report that we published will reflect that. So thanks for putting that out, Jeremy.
It's the papers as well, because they'll go on the website.
Okay, that's really helpful. We will make sure that action is followed through. Joe.
Thank you, Johnny. My comment is just in reference to page 148, inclusion, health and plus groups framework. I suppose just a little bit of pushback from me in terms of the first 2 points in particular, where we've got what we do well, lived experience, patient experience and patient voice. I think for me, as a broad group, we do that really well, but I think I would like to see that more in what we could do more, because I think from a health inequalities, health inclusion, I think there's still a lot for us to do. And I think in particular, again, around the lived experience networks, I think there's still a lot of work for us to do. I think there's great work going on, but in terms of consistency and across the board, I think there's still more for us to do.
So thank you. Phil?
Just a quick point. I think as you alluded to earlier, Chair, that this is a really important area and it's great to see the detail of some of the stuff that we do. I just wondered if there's a way in which we could bring this back more frequently, therefore, to board, rather than just be an annual report, maybe every quarter or something, but just to sort of see and have a look at the progress that we're making in this area.
We wouldn't want something as long as this, but the idea of making sure it's uppermost in our minds makes good sense. Should we take that offline, and Bijou and I and Alistair can discuss the most effective way of doing it? Is board open to the idea of getting more regular updates on health inequalities in some concise form? Yeah. And then I'm about to move
It
this on.
might also be worth a developmental session where actually I think there's a bit around a deep dive. As a board, it developmentally might make some sense. We could have brief updates, but I think that the value might be in sort of a deeper dive in a development session.
Okay, that's also a good idea. Let's take that forward and reflect on that. So, thank you. I want to repeat my thanks to Johnny. I'm also a member of the Inequalities Board. Find it extremely valuable, and I'm very aware of how important it is to the delivery of our strategy. We've had a bit of discussion about whether some of the self-assessment is maybe a little bit too optimistic, and there's a commitment to have another look, but we've also heard that is partly in response to the way in which the self-assessment tool is framed. We've got a particular suggestion that we should be logging the need to be doing more on the lived experience of some of the +5 groups. We've heard the opportunities for expanding our work on alliance-wide basis, and we know there's just a little bit of typing to do with the data, which means I think, to make sure that it's aligned, which means I think what I'm asking is for your approval of this report subject to some minor amendments that I guess Alistair will lead on undertaking. If there's anything major, he'll come back to me, but otherwise I'm asking for your approval of this report subject to the need to do some minor tidying. I think that's all agreed. That's great. Then thank you very much indeed. Now the next, this is rather exciting, isn't it? The Health and Care Academy. Emma, you're going to tell us where we got to. Maybe a little bit more than that. Tell us what we're planning to do.
Yeah, thank you for inviting me along today. I'm Emma Dawes and I'm Head of NMAP Education and Workforce Development. I've got some slides to show you in a moment. I'm going to take that you've read the report that I've written.
Oh, yes.
I just wanted to highlight 2 things of note in there. And the first thing is the absolute success we've had with the university partnership. I think it was a very big ask when we went out to tender, and the University of Sunderland have really stepped up to the plate and supported us in our aspirations to do that. They've been a very solid partner. They've offered very good advice and guidance over the last year and really supported us to get to where we need to be to open next month. And the second thing that I want to mention that's really of note is that we've had professional regulatory body approval to train nurses at that site. It makes us only the 3rd in the country and the 1st in the region to achieve that. It's normally only universities who are approved to deliver pre-registration programmes, and that's done in a very controlled and with very tight criteria, and we went through a very rigorous process to apply for that status alongside the University of Sunderland, and we have been successful. We were really delighted, and then we thought, oh crikey, we're going to have to do it now, but we're absolutely ready to do it. I thought I would use the few minutes that I've got with you today just to give you a bit of an update on the building and show you some pictures of what it looks like on the inside. So this is just the middle floor. The ground floor is a GP practice, top floor, conference facilities, boardroom, so I know you'll get to visit it before too long. The fire extinguishers haven't been delivered yet, so we're not allowed in just yet, but we're almost there. So this is the outside of the building. Anybody that's been to the NSEC site will have seen that. They'll have driven past it as they've arrived on site. That's just the artist's impression, but I've actually got some live pictures for you. So I'll just talk you through some of the academy facilities. So this is the middle floor. It's the footprint of that middle floor. The blue squares that you're looking at the moment are teaching spaces. They are the classroom areas where we'll do the academic teaching. This is what they look like now. You can see it's still so new. There's still plastic on some of the chairs there. But we have 8 classrooms, space for 120 staff in there. We've got state-of-the-art IT facilities, university standard IT facilities in there. So we've got amazing, I keep talking about the whiteboards because they're new to me, but it's a whiteboard that, sorry, I know. Really, and I know, spent a lot of money, but we've got whiteboards that are interactive, that can show films on them, we can open up joints and look inside bones and things like that on them. And we also then have the ability to press a button and it turns the whole lesson into a QR code that the students can download onto their phones. So it really just brings everything right up to date as we could possibly get it. We've made it a dynamic teaching space so it can swing between clinical and academic learning, and plenty of space for clinical skills training, which is obviously essential. So our simulation areas are just outlined here. So we've got 4-bedded ward. It's a little bit bigger than we'd need for 4 beds, so we can put a whole class in it. We can have groups standing around each bed, and again, all the high-tech facilities that we need in there for simulation. Cameras, control rooms. That PCPI room there, that's patient, public and carer involvement. So they're the people that we'll be bringing in patients. So if we're teaching about diabetes, we'll have a volunteering with diabetes, who'll talk about what it's like in their life to live with that condition on a daily basis. And they're a core part of the programmes that we'll be teaching. We've given them their own room so they can rest away from the students should they need to, with tea and coffee making facilities and some comfy chairs in there. The immersive suite is an interactive space where we can project onto the walls. We can turn it into any space we like. We could turn it into what the operating theatre looks like at NSEC or a person's home, or indeed we can open documents on it and with our hands move them around the wall, and so it's a really immersive and interactive space. We have a consultation room for outpatients or GP simulation, and we have a small community bed sit in there as well. So here's just some pictures of those. You can see there, the B8 hasn't got the curtains up yet, but the beds are in. The consultation room, those comfy sofas there are where our patient volunteers will have their base, so they can come and go as they need. And that's the beginning of our community bed sit room, and we've got a range of furniture in there so we can make it look like a very cluttered and chaotic elderly person's home that the district nurses need to navigate around, or we can swing it the other way and make it much more modern. And we've got some IKEA furniture in there if we wanted to do home birth drills with the midwives. So we have the ability to swing between both, and we've had quite a lot of fun going around the charity shops buying various trinkets to put in there and cause the clutter that we're hoping to simulate. Student areas. There's a cafe serving hot and cold food. We have a wellbeing room that's got no tech, no IT in it if we need to have difficult conversations, or if there's a student that's distressed, we've got some calm space there. A fully functioning library that'll be stocked with everything that's on the reading list for the university. And that central atrium area, we've got breakout spaces so classrooms can spill out and do group work, or if they've got group projects, they can meet and have really good facilities. This is what it looks like, similar colour scheme to the Health and Wellbeing Centre at NSEC if anybody's been there, but we've tried to make it a vibrant and welcoming learning environment for the people that use those facilities. And just to note, the hexagon shapes you can see on the wall at the side there in the brown are acoustic panels, so any noise in that central atrium will be bounced back and won't go into the classrooms while we're teaching. We have some staff areas, and I'm not going to go through that list, but will all be hot desk staff that need to be there to teach will get a desk. If they don't need to be there, they need to work somewhere else. This is what it looks like, pretty standard, hot desk and space in there. So that's what the building looks like. We're very excited about opening. Our first programme starts on the 3rd of June, so we are really close to that happening, and this will be our first cohort of training our very own nursing associates. It's a real milestone for us. We're absolutely ready. And I think I just want to finish before questions to say we're absolutely aware of the size of the opportunity that we've been given here, and I hope you can feel some confidence that we absolutely will deliver for you.
Emma, that's just great. And today isn't so much the time to talk about the programmes that will be offered, that we've had some previous opportunities and we'll have some future opportunities. But that building, doesn't it look great? And we'll be seeing it soon because the board's going to be meeting there. Whereabouts? In those rooms that you showed us, where are we going to be?
The top floor.
In the floor above. Okay, that's
Which
fine.
is similar footprint to
Okay, that's great. Next time we meet, we'll have the chance to maybe be shown around your floor as well.
Absolutely, yes.
Good. Well, questions for Emma. Ross first, and then Margaret.
Excellent, well done Emma, really good work. Just a question about demand, because I know just anecdotally lots of people have been asking me about their sons or daughters and what a great facility. Have you noticed a strong kind of demand for people wanting to come there in the future?
So yes, we do have a big demand, and particularly from our staff. The programmes, the pre-registration programmes for nursing will be teaching will be apprenticeships, which makes them really appealing because they'll earn while you learn. They'll be on a salary while they're doing a pre-registration programme. Then they'll finish with no student debt, and that's a really good prospect, I think, for our local community and indeed for our staff who are maybe currently our support workers and have the ability but maybe not the means to train to be a nurse. So yeah, there's absolutely a lot of interest. And we'll be starting in the summer running boot camps for those who are interested to get them in the best shape at the point of application so they can be successful in getting a place.
That's great. Margaret.
Brilliant presentation and great to see sort of your enthusiasm in the teams. It's just a question about regulation in the NMC, because that is fantastic to get accreditation and approval. Was that in partnership or is that you can stand alone?
We're not standalone, so we've been accredited. It's the building's accredited. It's a satellite centre of the University of Sunderland. So no, I mean not yet, but you never know. You never know what might come in the future. But one step at a time.
You could be the first, yeah. And then you talked about pre-registration. I'm assuming you talked about adult.
Yes. Well, the Trainee Nursing Associate programme isn't branch specific, so we can train to anywhere. But for nursing, our next regulation will be to go for our registered nurse degree apprenticeship for adult. Yes.
But you haven't got that yet.
We haven't got that accreditation. We currently use a Northumbria University to deliver that training for us, but we plan to bring that in with the partnership with the University of Sunderland to do that. And it's probably worth just saying we've got funding to train 25 a year. If we need to use some of that to train mental health, paediatric or learning disabilities nurses, we have the ability to send that person to Teesside or to Northumbria on their programme and keep the adult ones with us.
It's fantastic, and I think obviously first steps, but the aspiration should then be also to look at AHPs and particularly around the associates there. Yes, thank
I
you.
think the aspirations are quite big, aren't they?
So I think just on that, Margaret, I think you've hit the nail on the head there in terms of fantastic, absolutely fantastic work, and the facility is really, really good. I think already, and I think this is going to have to be your challenge about how you almost stop and make sure we get this bit completely up and running, because there are a number of other programmes that I think both for ourselves and in conjunction with members of the Alliance that I think we can deliver that does a lot of what Emma's talked about. So through the apprenticeship route in particular, where it's opening up doors for some of our young people coming out of school who might not want to go through the traditional university route, that actually gets them into paid employment and gives them an education. And if you think, going back to some of the inequalities work that we've talked about, the future impact that has within the local economy is fantastic. I think we've seen a real benefit in terms of understanding as well from our point of view, our workforce planning, what we're going to need as our services develop in the future to try and get ahead of the curve. So I think there's a little bit of how does Emma and Marion and the team stop or at least slow us down a little bit just to make sure we've got this up and running. But I think the opportunity is absolutely massive here.
I think we need to give Emma and her colleagues permission to say not yet to those of us that keep coming up with very good ideas. Yeah, okay. Great. Well, Emma, congratulations. Lovely presentation. We really look forward to seeing it in detail. And we'll see you again. We'll see you probably next time, next month when our board will be there. That's just great. Thank you. Colleagues, we're running about 15 minutes behind. I'm reluctant to squeeze these next bits, so I think we might run on a little bit after 12 o'clock, giving you warning of that. Probably we'll run over by about 10 minutes, I think, but we'll still need to keep quite sharp for this next period. We're into the patient and staff stories. Jo.
Thank you, Chair. So you'll know that we try to bring a good balance of staff and patient stories to board. So I hope that this one has filled your heart today because it ticks many boxes in, I think, in both patient and staff experience. So again, I don't give any apologies for the length of both stories because I thought, given the model of care, it was really important to bring a variety of views and experiences to give a really holistic view of the model of care in Rothbury Cottage Care. So I'll start with the staff experience, particularly to give some context then for the patients and families' experiences. So the people that we've spoken to at Rothbury Cottage Care are the matron, two of the care assistants, one of them senior, and the acting manager. So in particular, the matron talks about the model of care. So within Rothbury they have, and keep me right, Marion, if I don't do it justice, 14 beds, of which they are a combination of residential and NHS beds, and that allows patients to do a transition. For some patients where it's appropriate have their NHS care, but for some patients make that transition into being a resident in an environment that they know and they're happy. I think one of the underpinning things that came through for me, because I was really learning a lot about Rothbury, was through these stories was the collaboration. So having the GP on site, the district nurses on site, provides a real opportunity for timely patient-focused care, where the staff work collaboratively, not only with the district nurses, also with the GP practice, but also with the virtual ward team. I think from a staff experience perspective, across all 4 stories, I just had in my head all of the questions we asked staff, and I thought, tick, tick, tick. They talk about teamwork, they talk about working together, they talk about fulfilment in being able to deliver the type of care that they want to deliver to patients. They talk about being personalised and patient-focused, and one of the last lines for one of the staff was, I really feel that I'm able to make a difference to patient care in this role, and for me that really struck home. So I thought it was excellent. From the patient perspective, we've got four perspectives, 2 from patients who are not patients actually, they're residents, 1 from a family member and another from a patient who's received palliative care. I think what comes across strongly is the environment. People talk about the beauty of the setting, the building, they talk about the care, the compassion, the sociability of being connected with others, the activities. I think one of the things as well, just going back to the staff experience that the acting manager talks about, is the localness of Rothbury, that it allows people to stay in a local area, keep connections with their local community, and having recent experience in my own family, I could really identify with that and how important it is when you get to that late stage in life, is maintaining connections with your network and staying in a local area. The family member talked about how the care that had been delivered gave confidence to her partner, particularly, and it doesn't say in the story, but I knew this gentleman was palliative. Particular example, I think, around patient-centred was one of the patients, it was their birthday and they arranged for a meal to celebrate in the day room. So I think lots and lots of aspects of excellent care and excellent staff experience up in Rothbury.
That's just lovely. Richard.
I think, like everybody else say, it was a brilliant read. Really enjoyed it. I know the population of Rothbury will be delighted that it has filled everything we and they wanted from us. I think that's absolutely brilliant. I think it'd be really good to share this with the Berwick Governor's constituency, so there's some feedback to them in terms of what patients and staff are feeling about the facility. I think this is a national case study. It must be, in what good looks like in rural delivered partnership between GP, care home provider, the NHS and the population. You know, not many rural areas will have the advantage of being able to start where we did with Rothbury. I think this is an exemplar of how we can move forward. it was lovely reading the words. At some stage, it'd be nice to see some numbers to go with it. And I think a post-project appraisal of the number of people that have gone through and how it's worked together with the fantastic words here will just help complete the story and I think the case study.
I mean, I'm conscious that we received a letter just the other day, Stephanie added and Vicky did,
Yes,
from the campaign group. You may want to say.
Yes, so just last week we actually went back as a group to Rothbury, to the people of Rothbury, with the very thing that you're speaking about, Richard, about some data, about an analysis, about how things have worked. And you know, there were, it was a very difficult start that we had. We inherited a few things, that we'd been going down one road, but actually the best thing about this, I think, for the whole group was the brevity of stopping and pausing and re-looking at doing it in a completely different way. And we got a huge amount of support from the trust and the exec team to do this, and it was absolutely the right thing to do. And so the group this week, Paul Pays and everybody that was on the group originally came together. We went through everything, went through all the data, things that we could do even better, the teamwork that evolved, and the Rothbury group are very happy with it, and it has been quite a challenge, the whole thing. So I think Bijou got a letter on behalf of the group to everybody just to say thank you for doing that. And I think it was a very keen reward for the staff that have been involved.
Any more on this one? That's great. We'll take up Richard's suggestion and we'll give some reflection through Ross and colleagues as to how can we make best use of this, maybe after the election, who knows, but there's some real learning and sharing, and there's real source of pride in that. Joe, you've also got the report, the patient and staff experience update. I'm going to ask you to be brief this time.
Yeah. So I suppose just points of notice, because everybody will have had a chance to read the report. I think we see excellent performance when we're looking at trust level, patient perspective. We're in the top 20% in terms when we benchmark ourselves for inpatients and ED. I think points of note is looking at some of the decline that we see when we look at site level for inpatients and ED for NSAC. So we see that we're falling out of the top 20% for the first time for our emergency department, and when we see a steady decline for inpatients when we're looking at NSAC. And for me, it very much reflects some of the conversations we've had this morning around, it relates to discharge and for weight, and when we look at ED in particular around pain management. We see strong performance across our real-time. We've got our ED real-time where we see obviously some variation in the scores, particularly around waiting time and pain management, and that reflects what we see in our patient perspective. So I think it's really important that it's that triangulation, isn't it, that we see a pattern and we understand that pattern. However, I will add the latest report for ED, although it's just the first, is showing some great improvements in scores. So we hope that continues for the second report. Community, really strong performance for community, 3,372 respondents, of just which 105 were negative. We don't ignore those, we understand those, and we deep dive to understand. I just met with Margaret yesterday from community. We've also done some detail about our new AI tool that we're using in the trust as a pilot. And what you see there is the score for the social media review. So this is public domain data, and what is benchmarked is against the national and the regional score. And as you can see, Northumbria's score at the time of the report, and still is today, is the highest when we compare nationally and regional. And we are exploring with MPC piloting using PEP for patient experience reviews on a day-to-day basis for them. And finally, just our staff experience. So for the staff experience, it was our second high response rate. We have seen 2 questions statistically decline, which is around recommending the organisation as a place to work, and I'm still happy that I chose this career. We plan to explore that more in our World Cafe with staff that we're having on the 20th of June. And we also explore that through our Working with Teams programme. 2 of our highest questions related to patient care within the organisation and how our staff feel about that, and I think that's very positive.
A great report, and particularly just to unlearn that triangulation thing. We don't need to talk now unless people really want to, again, about NSAC. is the reassurance to the board is we knew from earlier, from the performance data that there were issues there, we can see it in a very similar way in the patient and staff experience. That's a reassurance to me that our data is providing us with a rounded picture.
Yeah, and just on the element that Joe's talked about there in terms of the significant decline around Northumbria being a place to work, through my roadshows, that was one of the questions that we asked the people that attended those roadshows to understand. Obviously Joe and the team will do the further deep dive, but whether that was about Northumbria per se or working in the NHS, and the general feel from those people, and I appreciate we need to explore this further, was it was more about the NHS rather than Northumbria per se, but clearly we'll need to do more data on that.
Okay. Questions and comments? Happy to receive, as ever, exemplary report. Thank you, Joe. Then we're into the board walkabouts. Always highlight for me. The first one, Alan, you were at Wansbeck.
I was at Wansbeck with Marion, a very enjoyable visit. I won't go through it all in detail. I think the important thing is the summary, and linking back to one of the questions right at the very beginning from the governors is how are we going to prevent the Alliance stealing our best staff? I was very impressed with the quality and happiness of our staff. Everybody I met, and I met a lot of them, most are local, and they've worked their way up within the trust. The important thing is that many of them have been away and come back, and we have a happy and contented workforce, and I'm sure that's in no part due to the fact that we've got Marion, but we've also got a general ethos of having a very happy place to work. So, I thought it was a very positive visit. I wouldn't worry about our staff being poached away, because I think they'll find out what it's like and they'll come back. So, very positive report.
Thank you, Alan, and thank you all the board walkabout reports this time. You've become more meticulous about naming staff that you met, and we don't need to minute. You can assume it is an action that they will all receive a card of thanks.
Okay, thank you.
Well, any comments or questions to Alan? Okay, that's great. Then different kind of visit. Katie, you went to digital services.
Yeah, I did. I was driving this morning thinking, how do I summarise how good the visit was? And my husband and I, every night we go to bed, we always talk about what's the best thing that's happened and the least best thing that's happened in the day. And on the 9th of May, it was the walk around with Dave was the best thing that's happened to me that day. I think that's sort of...
What a rubbish day, yeah.
I think that's what the worst thing was.
But my husband did question. No, it was brilliant, and there were clear themes that are coming out. I mean, the facilities there now that the team's consolidated are wonderful. The environment there was great. The smiles across the team was just lovely to see. They were really pleased with the strength of leadership, the presence of leadership there, their ability to innovate and to test things, but knowing that they've got that control to make sure they're moving in the right direction. Project management was brilliant. It was great to see that continuous improvement theme, which was lovely. And also just seeing how flexible working is really now something that they're happy with. And talking to somebody who's just started the week before, he was so pleased with the induction and the culture of the foundation, of the trust. It was all just so positive, and I left with a really different thought about digital services, and I just had no idea just how connected it is with the trust and how much clinical experience there is within the team. So yeah, it was a great visit.
Wow, these are really positive reports today. Anybody want to add anything? I'm slightly looking at you, Andrew, but you don't need to.
Well, I don't think I can really. It's just a testament to all the work that's gone over the last few years. So I won't try to add anything to that. But well done.
Great. Any more on that one? Then Richard, you were at North Tyneside, North 1920.
Yeah, and I think both Alistair and I were really pleased to have actually spent some time in the around some of the mental health wards at North Tyneside. We spend a lot of time looking at CAMS, the child end of mental health provision at the board, probably less time on older people, so it was good to spend a bit of time on that. Both very well kept wards, both very calm, and an enjoyable experience. We've noted from previous health and safety reports the concerns over the high level of reports of patient abuse towards staff, so I was very eager to be able to discuss that with people on the ward. And I think reassuring that although there are incidents, that they feel empowered and able to manage them. That felt reassuring from the visit. So that was good to see, and I think it was a good day.
Excellent, excellent. Any questions or additions? I think that point about making sure that we keep mental health and adult mental health in our sites is a really powerful one. Okay, that's great. Last time round in our walkabouts, Ned's had been asking about just checking on Feeding to Speak Up access, whether staff understood it. Can I just ask you to, when it feels appropriate, ask those same questions next time round to keep us going on that, to keep us ashore. Great, but that was a lovely set of reports. Then let's move on, shall we? There's some more, dare I say it, more formal. We've got one governance item, the CQC Regulation 17 for quarter 4. Ross, you need to take us through to check that we're compliant.
Yeah, just to say, Chair, we're fully compliant. I think it probably links in with the previous report we mentioned, so nothing in particular to pick out, other than to note lots of positive examples of engagement and how we are linking in with all the various communities.
Okay, anybody want to raise an issue? It feels pretty straightforward to me. Confirm that we're compliant, thank you. Then we're into, let me just get it. Items for escalation, and we've got the nursing and midwifery staffing and assurance support.
Yes, you'll all have had a chance to read through this, but the main things I wanted to bring up were the decrease in the number of staff moves, despite it being very busy. Also the decrease in sickness and the decrease in vacancies, particularly in medicine and emergency care business unit. I know the teams have been working very hard collaboratively on that with HR, with the nursing teams and with the managers. I think as well, I think going into sort of April and into May, April was going into obviously Easter. I think we will see something next month that maybe will be slightly different because it has been particularly busy. But on the whole, very pleased with that, particularly about the reduction in staff moves, because as we know, and particularly with Jo and the work that she does, that absolutely increases staff experience if they're not moved. Very happy to take any questions.
Okay, thank you. Encouraging trend movement in this dashboard. Yes, Margaret.
There's a much more, we can see a dramatic improvement going on. Just when I was looking at the dashboards, Wansbeck seems to stand out with fill rates and vacancies. Is there anything specifically that we're focusing on in Wansbeck?
Yep, so Elaine and the team are, Margaret, it's a good point made, and I think we've got some of the internationally educated nurses going there now as well, in groups, but also it is sometimes quite a struggle at Wansbeck, and it actually comes in waves. We're in one of these waves at the moment that we are targeting there. Sometimes in surgery and orthopaedics, or the orthopaedic side of things, sometimes struggle at Wansbeck. So it's targeted, we're looking at that all the time, and it's just about trying to get the right person into the right post. So we'll keep working on that.
So we're on the case. We're on the case progress. Thank you. Yes, Andrew.
Can I just flag one thing I really liked on the dashboard, having a page afterwards with the definitions of the data.
Yeah.
And we've been having a conversation about trying to do a bit more of that. I know there's been lots of really good work going on, especially around sort of joining up HR, finance, data, that kind of thing, but I just thought this sets a really good tone in here, so it's really helpful.
Well, that's good, and Chris and the team have been working very hard on that, as we've just been trying to make the dashboard more and more sophisticated, but easy to read.
Good, so we welcome the overall evidence of improvement, noting there's still some work to be done in Wansbeck, and we particularly welcome the descriptors, so we're to help us all understand what the data is that we're looking at. That's great, and Marion, you're still on for the allied health professional staff.
So I've just put that out, and it's thanks really to Margaret for encouraging us really to get going with this. I think this is the second one that I've come to the board with. And again, we're just going to sort of tidy that up a wee bit, but you can see that there's a huge amount of information in here from all of the groups. One of the groups that I'd probably like to highlight, and Margaret and I have discussed this actually before, is about occupational therapy. You know, it is a huge issue nationwide, but in the Northeast and in our trust. Delighted that Estelle, one of our leads for occupational therapy, has done a lot of work with this, and we are getting our recruitment back to where we want it to be. But again, that's something that we will keep an eye on, and we will probably come back with a sort of focus of one of these key allied health professions, just to give a flavour of what they're like. But any suggestions anybody's got, as I say, this one is in its infancy, and you can see sort of on the group that on the right hand side, that Sarah, our lead, has put in just really about the NMAPS conference, but also about what we want to do sort of coming up, particularly with the likes of podiatry apprenticeships and things that we haven't really done before that we actually want to do, and that'll link in very well with the Health and Care Academy when the time's right.
Very good. The only suggestion I've got is we probably only need the most recent month.
And that's
in
what,
the
so
pack.
that's why I only
That's why you put it on.
just generally do even the last one, yeah, good.
Margaret, any comments? Are you happy that we're making progress in the way?
I think we're making great progress, fantastic. And obviously whatever I'm going to say you already know. I think the slight worry is we've just seen a little rise in sickness in our AHPs, and particularly some of them, and it is related to where there is vacancies. But I know you're on it, I know the team are on it. Really appreciate the dashboard, I think it's excellent, so thank you.
Good, happy to receive that. Okay.
Sorry, just to comment on the turnover, which links to the absence, it's probably worth in PCC us doing a bit of a deep dive into some of these areas because they're quite high. There'll be low numbers, but they're high percentages. Just to look at that in a bit further detail.
Great. Yeah, we would welcome that, Kate, and that's really why we wanted to really put it together in a dashboard to focus on these areas.
Very good. Jeremy?
So it's just really just to link back to conversations around flow and discharge, and I just wonder whether it's worth specifically having a conversation about how we might change certain aspects of the discharge process so we become less reliant or more resilient when we have those particular staff group members. That was a bit of a conversation we had, I think, as you know, around these excellence.
Good, creative way of thinking. If we can't recruit staff, let's see if we can manage without it. Yes, yeah, very good, very good. Good, so welcome the progress with this report. Do a bit of deep dive at P&C on the sickness absence issues. Learning from desks, quarter 4, Jeremy?
Yep, so I don't propose to go into any detail around the particular incidents around learning. We had a good discussion at safety and quality. It's just really to say that after a fairly long winter, it is always a leaner period trying to get the reviews done through winter without emerging out of that, and the mechanisms for learning from death remain ticking over very nicely, and overall our data looks to me to be in a good place.
Excellent, this has been properly chewed over elsewhere, so Amy, happy just to receive. Chris, then you're on with the corporate safety and quality report, which has similarly been chewed over quite thoroughly elsewhere.
Yeah, thanks, Jeff. So yeah, we've heard also this morning from medicine colleagues around the ED 4-hour standard and ambulance handovers, and where we're at with that and the action plan around that. A couple of areas where we're progressing well around referral to treatment times from the 18-week standard, and around the number of over 52-week waits that we have is reducing. Similarly in diagnostics, we're holding and maintaining a good position there. A couple of areas of focus that teams are working on in the past month and the current month is around cancer standards, specifically around the 62-day treatment. Lots of work going on in neurology, tumour side. And also, the bottom of the complaints, we've improved in terms of our percentage within the target date. Not quite where we need to be, but we have a meeting on the 3rd of June with all the kind of internal stakeholders on that process to hone that a little bit more to make sure we're getting the complaint responses out in line with what we need to do.
Thank you for that. Questions, comments? Happy to note. Corporate financial compliance report.
Thank you, Chair. This report was clearly discussed at the Finance Committee on Monday, so just to highlight strong performance for the first month of the year, slightly ahead of plan in terms of the IE performance, 156,000 positive variance. Capital expenditure slightly higher than planned, but it's a phasing issue rather than any poor control on spend. I'll conclude on that point.
Thank you. Given the amount of scrutiny it's had at FIP, anybody want to add at this point? Then thank you. Two final items then. Review of the meeting, how's it gone for you? We're already 5 minutes over. I apologise for that, but one of the things that came up in my appraisal is don't be quite so anally retentive about time. Use the opportunity. So here we go.
Should I quite say that?
No, maybe we didn't quite say that, but any comments? But as ever, we should be open for ways of which improving how's the meeting gone?
Okay.
All okay? Good, fine. Questions from the public? Keith?
Thank you. Is there a little dance routine?
Button on the bottom and the button on the top.
Oh, right. Thank you very much. Thank you. Thank you, Chair, and thank you all for your patience. My wife hates me coming to these. I'm not going to tell you what we spoke about last night, but it was little to do with the trust. But anyway, welcome back, Bijou. It's good to see you here. You were missed last evening. It was an excellent meeting, but just think that our friend did better than you, actually. I am touched by the positivity in this room. It's absolutely extraordinary. And mixed with the honesty and the humour, it's just absolutely fantastic. This trust goes on and on to amaze me so much. Someone should bottle it, and then we could just sell that and we all can retire. It'd be great. Trying to understand from my point of view as governor, what's in other governors' heads. I'm the lead governor for what that's worth, which is nothing because our trust isn't in any trouble, so it doesn't matter. But I do try to understand what's in government's heads should the day ever come that we're asked. And equally, I try to know what's in our NEDs and directors' heads, and yours even, which is frightens me somewhat. I don't know, get into some of them. But it is a pleasure to come and spend time and listen. From the very basics, if you like, when the government moans about something, to ultimately being discussed by board and priced out and all that thing by the bean counters, to eventually get here and to see us going forward, and even more than forward, ahead of the game in many respects. It's absolutely fantastic, and I thank you all so much for what you give to the Trust, for peanuts, frankly. Beats me why you do it, but nevertheless, from the government's going to say thank you so much for what you give to the Trust. Thank you.
Keith, that's just terrific, and I'm really grateful, and I know the rest of the board will be equally grateful for that. That's great, and what a terrific note to finish on. So we're winding up coming up to 12:10. Our next meeting is in 20 minutes' time, so we will see you back here once you've had a chance to grab a sandwich or whatever. Thank you very much indeed. Cheers now.